Hello and welcome to Ortho Art. My name is Khalid Al-Awadi. I am a final year medical student at Kuwait University. Today we'll talk about the orthopedic shoulder examination. So these are my references for this presentation. So as a quick disclaimer, this presentation is intended for clinical year medical students at Kuwait University. Always adhere to your local medical school guidelines on examination and clinical skills. Finally, I would like to thank the Kuwait University Medical Students Association, KuMSA, for the contribution, especially the Standing Committee of Medical Education, SCOME, and the Clinical Subcommittee as part of the Kuwait University Medical Students Association. So before I enter the table of contents, make sure you check out the description down below to check out the timestamps you wish to go to each part of the video or each chapter of the video to view at your disposal. So start with table of contents. So as always in orthopedics, case scenario, examination settings and tips, wipe, look, feel, move, neurovascular status, special test, and then we ended with common questions. And one tip is you make sure again to comment on what will you do in every step as you go throughout the orthopedic examination, as it differs from medicine. In medicine, you're asked to examine this patient and report the findings back to the examiner. So we'll start with the case scenario. So this is Mr. R. He's a 26-year-old professional Australian rules football player. It's like the football or rugby player in the UK. Presents to you at the sports clinic with right shoulder pain after a collision with another player during a match. After checking a proper history, please examine this patient in an orderly fashion according to his main complaints in 6 minutes. So this is a video of the accident, what happened to the patient.
Sons forward again. Carmichael Hunt back in the team. Here's Riley, I mentioned him. And that's run over the line.
Got a shoulder dislocation down there with Riley, he was dropped last week. That's out. That is out. That is sitting 2 inches lower than it should be.
Just take a look here. May with the bump on the shoulder.
Oh, yeah.
And then bang.
So for the anatomy, you have to know your anatomy very well, as you'll be asked during or after examination, plus its clinical significance. So this is a legend of a drawing that I made regarding the shoulder joint. So in examination settings, always you have to, in any setting of the examination, you check for wipe, look, feel, move, neurovascular status, and special test. This is always an orthopedic examination. Another tips you have to do in an orthopedic examination, because of COVID-19, it's difficult to examine patients, as almost any patient in surgical patient you have to treat them as COVID-19 positive. So always practice with your colleague and apply the clinical practice and knowledge to enable to practice and to make sure you correct your mistakes during the examination steps. And examine also with start examining on a family member as a simulated patient. So start first with wipe. So first in wipe, so wash your hands, introduce yourself to the patient and examiner. Ask the patient for permission for examining his shoulder, and asking him, I'm going to perform the shoulder joint examination, which involves examining your shoulders. Is that okay? Then you expose both of the patient's shoulders and the upper limbs until his waist while he is standing. This is very important, you have to mention. Then we'll start with look. So always examine on both sides. Make sure the patient is on a standing position. So on inspection, while the patient is standing, you always look at the shoulder from front, sides and back while he's standing. So look at the soft tissue, the muscle bulk, and the skin and the bones. You have to look for skin changes, erythema, lacerations, scars, arthroscopic repair for multiple pathologies you want to look for, as shown here, evident by this image. So this is an arthroscopic scar for rotator cuff injury this patient had, and these are the scars. So as you can see, the scars is less than 1 centimeter, less than 1 centimeter the size of the scars, and this is an arthroscopic repair. Then you check for loss of contour, or you have to check for asymmetry. Like for example, loss of contour, like a common example of that is glenohumeral joint or shoulder dislocation. So you compare one right side to the left side. One side is shorter and lower than the other side, which is the normal one. So you have to examine that side and check if the patient had dislocation or a fracture, a clavicle fracture. Then check for swelling or a mass in that area. Check for deformities, a biceps tendon rupture, a glenohumeral joint dislocation, a clavicle fracture. You have to check on these. Then you have a muscle atrophy and a wasting. Example of that is deltoid supraspinatus fossa or infraspinous fossa. Then a scapular winging. So this is a picture of a loss of contour or asymmetry. So this is the glenohumeral joint dislocation when the acromion is prominent, shoulder is flattened, the humeral head is prominent, the arm is slight abduction, the elbow is flexed, the forearm is internally rotated, supported by the other hand, and the anterior and posterior differs in only if the arm, if it's in a slight abduction versus adduction. So this is the patient had a distal bicipital tendon rupture, avulsion, some people call it, or some people call it the Popeye sign, like the Popeye series, animated series in the 50s, when he takes a can of spinach to gain power, then he starts gaining muscles, the biceps. This is one of the muscles, one of the signs shown here. Then you have a scapular winging evident by this area. So this is a scapula, the right scapula. It has weakening because of the scapular winging. So which affected muscle and nerve and contributors to the nerve is long thoracic nerve. The muscle affected is the serratus anterior. And as part of the loss of contour or a deformity is a clavicle fracture. It's evident here. So there's a discontinuity of the clavicle evident here at the distal third of the clavicle. And finally, the muscle wasting. As you can see the spine of the scapula. The infraspinatus and the supraspinatus are affected, and also you can see the medial border of the scapula. Then you proceed with feel. Always you have to examine both sides. Before you palpate or touch the patient, ask the patient, do you have any pain in your shoulder? This is a must. We have to check. So palpation, start from medially to laterally. So we go here. So medially, we examine the sternoclavicular joint. Palpation, you want to check for tenderness or a step, as evident here, or dislocation. Then you palpate the clavicle palpation. Palpate the clavicle. Then the acromioclavicular joint here, at this area. Check for tenderness and instability. Then you palpate the glenohumeral joint, which is here. Check for tenderness or decrepitus. You could have an arthritis, loose body, fusion. Then you palpate for the bicep tendons and the bicipital groove, evident here in the intertubercle groove. Then you palpate the scapular palpation along the medial border. Check for tenderness, scapulothoracic dislocation. So this is a video of showing you the palpation.
Feel for deformity, tenderness, temperature and swelling. Start at the sternoclavicular joint, moving along the clavicle to the acromioclavicular joint. Feel for the coracoid process. Around the acromion process, and then move along the spine of the scapula.
Palpate the tendon of the long head within the bicipital groove between the greater and minor tubercles. If the patient's arm is palpated while rotating the arm in and out, the tendon should be detectable as it moves. Tenderness may be a sign of an inflammatory lesion or a degeneration of the tendon. A noticeable click suggests a subluxation of the tendon.
Then we proceed to move, range of motion. always before you examine or perform passive range of motion on the patient or palpation, ask the patient, do you have any pain? This is a professionalism. You have to be very professional with the patient. So start with active, then passive. They'll always start with active range of motion. If limited range of motion, you have to perform a passive range of motion on that specific area. You have to make sure the patient is copying what are you doing, as you're doing in spine examination. In spine examination, you ask the patient to perform exactly the steps that you are doing. Start with forward flexion, extension, adduction, external rotation, and internal rotation. Flexion, extension, adduction, abduction, internal rotation, external rotation, and there's also an external and internal rotation at 0 degree abduction and also at 90 degrees abduction, which I will show you later on in the special test. Then you ask the patient to perform the patient's and the quick screen maneuvers. When you ask the patient, hands behind your back and hands behind your head, to examine certain functions. So this is a patient, you ask the patient to do internal rotation either from the front. This is a patient asking from the back with the thumb up to reaching T4 to T8. This is a normal.
First of all, if you could put both hands behind your head and push your elbows back. Fantastic, and relax. And now if you could, with both hands, reach up your back as far as you can. Brilliant, and relax again. Okay, James, we're going to do some further movements now. If you could just copy what I'm doing. First of all, if you could bring your arms out in front of you as high as they'll go. Now bring your arms back down and take them back behind you as far as they'll go, like this. Fantastic. And relax. And now bring your arms out to the side and all the way to the top like this. Brilliant. And take your arms back down and bring them across your body. Fantastic, and relax. And now tuck your elbows in like this and bring your arms out and then across your body like this. Move your arm for you now. If you just stay as relaxed as possible. Please let me know if you have any pain at all.
Then you check for neurovascular status. In every orthopedic examination, you have to examine each nerve and its function. So sensation, you have to examine the dermatomes of the following nerve, the axillary nerve, then the musculocutaneous nerve, then the medial and the brachial, antebrachial, or sometimes called the medial and lateral brachial cutaneous nerves. These are sensory nerves. They don't have a motor function. Then a median nerve, shown here in light green. Then the radial nerve, shown here in the pink color, the dermatomes, and then the ulnar nerve, which is shown in the blue color. Then you check the motor function of each nerve. Now vascular, you have to palpate for the brachial artery, radial artery, and the ulnar artery. So the brachial artery, so this is a location. So this is antebrachial cubital fossa. So you palpate here. You go medially to the antecubital fossa and you palpate the brachial artery pulse. The radial artery pulse, you go laterally and you palpate the radial artery pulse, and then you have the ulnar artery at the same area. You palpate for the ulnar artery pulse. So this is a summary of the motor and the sensory the function of every nerve. So let's start with axillary nerve. From its name, the axillary nerve, it palpates, it innervates the deltoid and the teres minor muscle as a motor function, and the sensory on the lateral shoulder. It's like mentioned as a sergeant patch in the military. So usually in the military, the patches is placed on the lateral side, which is shown here. So the function of the deltoid and the teres minor is abduction of the upper limb at the glenohumeral joint and external rotation of the shoulder. Musculocutaneous nerve, part of the C5 and C6, it innervates the lateral forearm, shown here at this area. And innervates the muscle in the anterior compartment of the arm. As a mnemonic, it's BBC. So biceps brachialis, coracobrachialis. All of them act in the flexion of the upper arm and the shoulder. Why? Because, as you know in anatomy in third year, so always the anterior side of the arm and the shoulder acts for flexion. The posterior side acts as extensors. In the lower limbs is the opposite. The front are the extensors, the posterior are the flexors, with some exceptions. And as I mentioned earlier, the medial brachial and antebrachial cutaneous nerve, whether it was medial or lateral, they act as sensory nerves, and they innervate the dorsum of the hand. Now you have a medial nerve, which is part of the C6 and C7. They are the sensory from the palmar part of the thumb to the radial half of the fourth digit, which is shown here in the light green, and the dorsal tips of the first, second, third, and 3.5 radial of the fourth digit. The remaining 1.5 is innervated by the ulnar nerve by exclusion. So the medial palm and the dorsal of the hand, the fifth, and medial half of the fourth digit, the light blue. So for the medial nerve, they innervate the wrist flexure, the flexion of the second and third digits, and pronation of the thenar muscles, which is the thumb. Their job is to pronate the forearm, flexion of wrist, and flexion of the digits of the hand, especially the index and the middle finger, and the thenar muscles of the thumb flexion. Now the radial nerve, they innervate the lateral dorsum of the hand, shown here with the light pink, and the medial upper forearm, and the dorsal surface of the lateral 3.5 digits. They innervate the triceps brachii, the extensor muscle of the forearm, for the finger, thumb, and wrist. So their job is to supinate the forearm, extensor of the wrist and finger joints, and they extend the arm. The ulnar nerve, they innervate the muscle wrist flexors and adductors with flexion of the fourth and the fifth digits, which is the hypothenar muscles. Now, from its name, flexor, carpi, ulnars, flexor as flexors, carpi as the carpal bones, the ulnars is the ulna. So it flexes and adducts the arm at the level of the wrist. Flexor digitorum profundus, from its name, a medial half, so it flexes at the ring. Then we end with a special test. In every in shoulder, we have to examine 6 things: impingement test, rotator cuff test or test, labral injury test, the biceps tendon injury test, glenohumeral stability test, and acromioclavicular joint test. Start with the impingement test with 2 tests: near impingement sign and the Hawkins or Kennedy sign. So the near test, when the scapular motion is prevented with one hand, the arm of the patient is forced to be elevated at an angle between flexion and abduction by the other hand. A positive sign is elicited when the pain is elicited while passively moving the shoulder at the elevation, meaning the greater tuberosity is being impinging against the acromion. The Hawkins sign, almost the same interpretation and positive sign, but the technique differs. So it performs when they flex the shoulder at 90 degrees, flex the elbow at 90 degrees, and forcibly internally rotate, as shown here. So flex the knee, shoulder 90 degrees, flex the elbow 90 degrees, then forcibly internally rotate. But make sure before you do the test, you have to stabilize the scapula to avoid any masking. Now this is a video of the summary of the impingement test.
From the near test, the patient is in sitting position. You're going to stand behind the patient and use one hand to stabilize the patient's scapula. Then bring the arm into maximal passive shoulder flexion. Test is considered positive in case of the reproduction of the patient's familiar shoulder pain during maximal shoulder flexion. To perform the Hawkins-Kennedy test according to its original description, have the patient in sitting position with the affected arm in 90 degrees of shoulder flexion and the elbow flexed to 90 degrees. Then fixate the scapula with one hand and hold onto the patient's elbow with the other hand and add passive internal rotation to the glenohumeral joint. The test is considered positive in case of the reproduction of the patient's familiar shoulder pain.
Then we have the rotator cuff test or test. So each examination step is examining a certain muscle, except the external rotation lag and the drop or hornblower sign. Both of them are almost the similar steps, examining the same muscles, the infraspinatus and the teres minor. So start with the empty can test. From its name, you're trying to empty can. So duct the arm at 90 degrees, angle forward 30 degrees, bring it into the scapular plane. You have to make sure of that step. Then internal rotate. The thumb points to the floor, then press on the arm when the patient attempts to maintain position. So you examine the supraspinatus muscle. A positive sign indicates that there's a pain or weakness at that area. External rotation lag sign, which means passively flex the elbow at 90 degrees, shoulder elevate at 20 degrees, hold the wrist to rotate the shoulder to maximal external rotation. Then tell the patient to hold that arm in external position. Then you have so this is how you do it. So basically, you flex the elbow at 90 degrees. You elevate it a little bit at 20 degrees, holding the wrist to rotate the shoulder to maximum external rotation. Then hold that arm in external rotation, as evident shown here. If the patient unable to maintain the external rotation, he will try to see a lag sign and try to adduct it back to internal rotation. This is called a lag in external rotation, and depending on the angle, usually is more than 5 to 10 degrees. This is a positive sign. A dropped or a hornblower sign is almost similar, the same technique. So bring the shoulder to 90 degrees abduction, 90 degrees of external rotation. Ask the patient to hold that position. If the patient unable to maintain the external rotation, the arm will fall into internal rotation of more than 5 to 10 degrees lag. So this means there is a major rotator cuff tear. Most likely the affected muscles are the teres minor and the infraspinatus. Now the belly press test, you ask the patient to press on his abdomen with the palm of the hand, maintaining the shoulder and internal rotation with the elbow anterior, the elbow at the same level of the hand, not going backwards. So make sure it's the same level, as shown here in the picture. A positive sign that the patient will be unable to maintain maintaining the belly press test, the internal rotation, the elbow will drop back, does not remain in the front of the shoulder or at the same level, meaning either the weakness or there's a tear in the subscapularis muscle. So this is a summary of the video summary of the rotator cuff test.
The empty can test, the patient is in standing or sitting position. The arms of the patients are elevated to 90 degrees in the scapular plane. The arms are then fully internally rotated so that the thumbs point towards the floor. The patient is then instructed to resist downward pressure applied by the examiner. A positive test is indicated by weakness and or pain of the affected arm compared to the unaffected side.
To perform the test, support the patient's elbow at 90 degrees and support the shoulder in slight scapular plane abduction and near end range external rotation. Instruct the patient to hold this position whilst you release their forearm. A positive test is indicated by an inability to maintain this rotation with a lag or spring back occurring. A lag of 5 degrees or more indicates a rotator cuff tear. This test can also be repeated in 90 degrees of abduction. Here, a spring back is known as the drop arm sign. On the test, instruct the patient to place the palm of their hand over their abdomen, with their shoulder in full internal rotation, which should result in the elbow coming forwards. The patient should then perform a belly press action using internal rotation of the shoulder. A positive test is indicated by the inability to perform this movement and posterior movement of the elbow due to subscapularis weakness or potentially a full thickness tear.
Okay, so this is shown here. Then you have the labral injury test. It's one test called the active or compression test. So people call it the O'Brien test. So you ask the patient to forward flex the arm 90 degrees, keeping the elbow fully extended, then adduct the shoulder 10 to 15 degrees as shown here in the picture. Then you ask the patient to pronate the forearm, so the thumb pointing down. Then apply it force to the wrist. When the arm in this position, when the patient resists, the patient then supinates the forearm when the palm is up. Then apply a force on the wrist while the patient resists. Usually a positive sign when the patient in the pronation position, the forearm, there's a deep pain in the glenohumeral joint, but not when they supinated. This means there's an injury at this slap lesion, or some people call the superior labral tear from anterior to posterior.
A more sensitive test for labral tears is O'Brien's test. Forward flex the patient's arm to 90 degrees, adduct it about 20 degrees, and internally rotate it so that her thumb is down. Ask the patient to resist your downward pressure. Next, externally rotate her arm so that her thumb is up, and again ask her to resist your downward pressure. A positive test is pain or painful clicking that the patient experiences when the thumb is down, which is reduced or eliminated when the thumb is up.
Then you have the biceps tendon injury test, either speech test or Yergessen test. So speech test, you ask the patient to forward elevate their shoulder against resistance while they keep the elbow extended and the forearm supinated. So ideally this patient, because he had a positive sign, he is unable to extend his elbow. So forward elevation, you have to forward elevate against resistance, and while they keep the elbow extended and the forearm supinated, and you should palpate at the area of the bicipital groove. You see pain at the level of the bicipital groove, either a tear or a tendon sheath synovitis. A Yergessen test is when the elbow flex at 90 degrees with the forearm pronated. Then you ask the patient hold the hand and the wrist to maintain pronated position while the patient is actively trying to supinate against his resistance. You ask the patient to supinate against resistance. The pain will be elicited at the bicipital groove, either because of a tear or a sheath synovitis. So this is a video summary of the biceps tendon injury test.
The speeds test is going to be checking for bicipital tendinitis. For this test, you're going to be asking the patient to fully extend their elbow and supinate their hand. Asking the patient to flex their arm against resistance. I'm going to compress down towards the ground. A positive test would be pain or tenderness up in this area. So I'm going to just perform this one more time and palpate. If there's pain or tenderness, it would indicate bicipital tendinitis.
Lesions. To perform the test, have your patient's forearm flexed to 90 degrees in full pronation and stabilized against the body. Then ask your patient to perform supination and resist the movement. At the same time, make sure that you palpate the biceps tendon in the bicipital groove. If you feel the biceps tendon popping out of the groove, this indicates a tear of the transverse humeral ligament. Tenderness or pain without the pop is indicative for biceps tendinosis or slap lesions.
Then you have the glenohumeral joint stability test. So you have three tests: apprehension test, or some people call it the dislocation test. You are attempting to dislocate the patient or having the sensation that the shoulder is being dislocated. The second test is relocation test. You are relocating the glenohumeral joint. Then the sulcus sign. It's the same as apprehension test, but however you're pulling downwards. So you basically are trying to exaggerate the dislocation. So the first one is apprehension test. So the patient is lying supine, bringing the arm to a 90 degrees of abduction and full external rotation, and the patient experiences a sense of instability. So he'll have a sensation that, the doctor, that my shoulder is being I feel my shoulder is going away. It's being dislocated. So this is anterior stability. Relocation is the same steps I did in the apprehension test. Add with it that you want to apply a posterior directed force to the anterior humeral head with the same steps. You will stabilize at 90 degrees abduction and a maximum external rotation. So this is apprehension and this is relocation. So this is another picture. So apprehension, if we create so that feeling that the sensation that the shoulder is being dislocated, that the consent disappears on relocation. You are not actually dislocating, just you're giving a sensation that the patient's shoulder is dislocating and relocated. Now the sulcus sign, so have the patient stand, relax with their arms on the side. So ask the patient to relax while standing. Grab the affected arm and pull it inferiorly. A positive sign, if there's a sulcus sign that forms at the superior aspect of the humeral head, now this is dimple sign, as shown here. Now interior and interpretation, that's the inferior component of the instability. It means that there's a multi-direction instability, or NDI, or joint hyperlaxity. It means more than one joint is involved in the injury, or more than one ligament involvement. Now this is a summary of the video. So the examiner, so I'll try to skip here. So the examiner will attempt to abduct at 90 degrees to apply apprehension test. Then external rotates, giving a sensation of the apprehension test that is designed to dislocate. Then pushing. Sorry for the typo. It should say here apprehension test. Then apply the posterior directed force into the glenohumeral joint, giving this sensation of relocation. If the patient had that sign, means that the anterior, it confirms the apprehension test. So my apologies. It should be also must be switching between the two examinations. This one should be a sulcus sign test.
Have your patient in standing position with relaxed shoulder muscles. Then grab your patient's arm distally to the elbow joint and pull the arm distally. The sulcus sign is the appearance of a little dip under the acromion or the feeling of subluxation, which is not the case in this patient.
So this is a positive sulcus sign. So he's trying to attempt to downward pressure. As you can see, there's a dimple sign at this area, level of the acromion, the clavicular sign joint. So he's repeating it again. Then finally we have the acromioclavicular joint test. We do it, it's a simple test, so we do a crossbody. From its name, crossbody. So we basically flex the knee 90 degrees, then adduct it all the way as much as you can across the body to maximal point. A positive sign that the patient will have pain or discomfort of the acromioclavicular joint. So either there's infection at that area, sprain, dislocation, or arthritis. So this is a video. So usually there's a lesion at that area. So this is an arthritis, or some people call it the Apley's scarf test. The other name for the acromioclavicular cross test. So he attempts to forward flexion 90 degrees and cross the body as much as he can of the shoulder. So we end the shoulder examination with common questions. So you'll be asked on the shoulder dislocation. Let's say this patient had a shoulder dislocation. As mentioned, the case scenario. How do you manage this patient depending on the scenario? If the dislocation, ideally in a situation with shoulder dislocation or any dislocation, you attempt to relocate as soon as possible to avoid any avascular necrosis of the shoulder, and then you have to investigate accordingly. Then you might be asked on the special test. In every special test, what are the test involvement of that specific area? Like say, for example, glenohumeral joint stability. What are the tests for it? How do you perform each test? How do you know which one is a positive sign? Another example, that let's say this patient shown has a clavicle fracture management. How do you manage the clavicle fracture depending on the scenario itself? Then finally you might be asked on the neurovascular status questions in every orthopedic examination. This is a must. I was in my station, I was examined on hip examination, and I was asked on neurovascular status questions and on the special test during the examination. So thank you for your attention. So this is the last video of the orthopedic examination series as part of Orthopedics Art in collaboration with the Kuwait Medical Students Association. So if you have any more questions, ask them in the comments down below, or send me an email to orthopedicsart@gmail.com. I'll be more than happy to answer. Thank you all for your time. Wishing you all the best of luck to my colleagues in 7th year, as our graduation is drawing near, and to our colleagues in 5th year, who's doing their surgery rotation and in the finals. If you're interested in orthopedic surgery, please let me know. I'll be more than happy to help you out. Thank you so much for your time again. Wish you all the best of luck. Bye-bye.